measuring small molecule and metabolites, formation, anabolism, and breakdown catabolism of biological molecules is central of life. Every living organism uses molecule as source of energy, as building blocks for cells and tissue, and metabolic sensor to control metabolism. Thousands of small molecules. For this section, we will consider small as above molecule weight of 1000 are created and destroyed in the metabolic process every day. Those that circulate in the blood or that are excreted in urine can be useful indicator for how well the body is functioning. Whether the patient is using and storing energy efficiently, eliminating waste product, and is healthy. Several commonly measured small molecules include those that reflect nutritional status, those that reflect the elimination of waste product, and those reflect metabolic control. Some examples of each type are given in the table below. A small molecule nutrition analysis the glucose description, a major source of energy for many tissues, regulated by hormones such as insulin, cortisol, glucagon, while measured. Test for diabetes, high blood glucose, reflecting insulin deficiency or insulin resistance in critical care setting to test metabolic status. The interval 74 to 106 mg per deciliter or 4.15 to 5.9 millimole per liter. Decrease and increased value. Diabetes, increase in diabetes, Cushing disease, stress, decrease insulin excess, starvation, adrenal insufficiency. Vitamin B2 required for red blood cell function and important in nerve function. To identify a deficiency when low iron, why we measure it? To identify a deficiency when low iron and large red blood cells are present, macrocytic anemia, and to monitor therapy for low vitamin B12. They range from 200 to 835 microgram per mil. Increase in some leukemias, decrease in malnutrition, malabsorption, pernicious anemia. Folic acid needed for red blood cell functioning and important for cell division, especially needed in pregnancy for developing fetus. Deficiency can lead to neural tube defects. Measure with vitamin B12 and determine the cause of macrocytic anemia and to monitor therapy for low folate. The range from 3 to 20 nanogram per milli. Increase in pernicious anemia, decrease in malnutrition, malabsorption in celiac disease or alcoholism. Total bilirubin. This breakdown product of hemoglobin is excreted by the liver into the bile. It circulates in blood into forms referred to as conjugated and unconjugated, reflecting whether the carboxyl group are free, unconjugated, or esterified conjugated. We measure it to assess the liver function. We use it to assess the liver function. The range from 4.1 total bilirubin from 0.1 to 1.2 milligram per deciliter. Increase in hepatitis, in cirrhosis, hemolytic disease, and obstruction of bilateral biliary and hepatic ducts. Obstruction of biliary and hepatic ducts. The direct bilirubin, conjugated bilirubin. The conjugated form is water soluble, made in the liver and excreted in the blood. It reacts directly with diazotase, and so it's called direct reacting. To test the liver ability to conjugate bilirubin and excrete it, the measurement less than 0.3 milligram per deciliter or 5 millimole per liter. It increases obstruction of biliary or hepatic duct as in hereditary conditions like Dupin-Johnson syndrome. Indirect bilirubin, unconjugated bilirubin. The unconjugated form is fat soluble and the product of hemoglobin breakdown. It reacts with diazodides only in the presence of activator, so it's called indirect reaction. Indirect bilirubin is calculated as total bilirubin minus direct bilirubin. It reflects the difference between the total and the direct bilirubin. The measurement 0.1 to 1 milligram per deciliter or 2 to 7 millimole per liter. Increased hereditary condition like Gilbert disease and Crigler-Najjar syndrome. Crigler-Najjar syndrome. Neonatal bilirubin, unconjugated bilirubin found in newborn whose liver are too immature to conjugate bilirubin. In neonates, conjugated bilirubin can enter the fatty tissue of the brain and central nervous system and cause brain damage, mental retardation, hearing defect, and cerebral palsy. Newborn are routinely tested for bilirubin to determine whether intervention is necessary to lower bilirubin and thereby lower the risk of brain and nervous system damage. The measurement from 3 to 5 days old, premature, less than 16 milligram per deciliter. From 3 to 5 days old for term, 1.5 to 12 milligram per deciliter. Increase in homolysis of red blood cells such as Rh incompatibilities, Kearney actress. Lactic acid. Lactic acid analytic description, why measured intervals and the increase and decrease. Lactic acid, this metabolite is released from muscle under condition of anaerobic energy production. Its high amount are released into the blood. It can disrupt acid-base balance, lactic acidosis. To evaluate syndrome, measured to evaluate symptoms that suggest poor oxygen delivery to tissue such as shortness of breath, muscle weakness. To evaluate patient in shock. To evaluate symptoms that suggest poor oxygen delivery to tissue such as shortness of breath, muscle weakness. To evaluate patient in shock, congestive heart failure, coma, less than 18 milligram per deciliter, shock, increase in shock, muscle fatigue, diabetic, ketoacidosis, tissue hypoxia, severe infections like meningitis. Uric acid. Uric acid, a waste product from breakdown of purine DNA component that is excreted by the kidney. Too much uric acid can lead to deposit of urine, crystals in joint, gout, and in kidney stones. To evaluate joint inflammation that may be due to gout, in order to monitor uric acid production in patients undergoing chemotherapy or radiation treatment. Male from 3.7 to 7.2 milligram per deciliter, female 2.6 to 6 milligram per deciliter. Increase in gout, kidney disease, and leukemia. Creatinine, a waste product from the muscle breakdown of compounds called creatinine, which is excreted in the urine by the kidney. To evaluate kidney function and monitor therapy for kidney disease. Creatinine may be measured in blood urine and both to evaluate kidney function. Male 0.7 to 1.3 milligram per deciliter, female 0.6 to 1.1 milligram per deciliter. Kidney dysfunction, which may be due to a variety of different causes such as drug toxicity, poorly controlled diabetes, or inadequate blood flow through the kidneys, as seen with shock or congestive heart failure. Urea nitrogen, blood urea nitrogen, a waste product from patient breakdown formed by the liver and excreted by the kidney, often ordered with creatinine to evaluate kidney function, also used to monitor dialysis patients. 6 to 20 milligram per deciliter. Kidney dysfunction, stress, high protein diet, low protein diets, and liver diseases. Ammonia, NH4, a waste product of amino acids breakdown convert to urea by the liver. Increased ammonia level can cause mental and neurological changes in the brain. To evaluate disorientation, confusion, and coma in adults, to evaluate irritability, lethargy, and seizure in newborn, the range from 40 to 80 milligram per deciliter. Increase in severe liver diseases, cirrhosis, severe hepatitis, Reye's syndrome, inherited genetic deficiencies. Thyroid stimulating hormone, TSH. Thyroid stimulation made by pituitary gland. It maintains stable amount of thyroid hormone T3 and T4 in the blood to screen for a diagnosis of thyroid disorder, to monitor treatment of thyroid diseases. Expected values fall between 0.4 to 4.2 milli international per mil. TSH is used for monitoring treatment. Highly sensitive cohort 3 third generation test called TSH is better able to measure TSH at very low levels. TSH is hyperthyroid with symptoms of anxiety. Decrease. TSH is hyperthyroid with symptoms of anxiety, weight loss, tremors, weakness, light sensitivity, buffness around the eye, blogging the eyes. Increased TSH is hypothyroid with symptoms of weight gain, dry skin, old intolerance, hair loss, and fatigue. Thyroxine T4 or triiodothyronine T4 is made by the thyroid gland and converted to T3 by the liver. These hormones control energy production, metabolic rate in tissue, both circulating with majority bound protein. As follow-up to the abnormal TSH test, lab test may measure either the total hormone or free hormone not bound protein. Interpretation of T4, T3 depend on the pattern of result from all three tests. TSH, T4, T3, and estrogen, a female hormone produced by the ovaries that trigger ovulation, to evaluate the causes of infertility and to assess menopause. Reference value different menstrual cycle phase for females level are seen after menopause. Dysfunction of ovaries, fail in pregnancy, polycystic ovarian syndrome, increased early puberty and tumor of the ovaries and adrenal gland. For male, increase in tumor of testes and adrenal gland, delayed puberty and enlarged breast. Both sexes, hyperthyroidism and cirrhosis and tumor syndrome. Decrease in tumor syndrome. Testosterone hormone responsible for development of male secondary sex characteristic. In female, it's converted to estradiol, the major female sex hormone, to evaluate infertility or erectile dysfunction in adult male. In boys, to investigate delayed puberty. In female, to investigate development of male trait virilization before age of 10. Value are similar in male and female. Value increase with age, especially in male, where there is a drastic rise at puberty. Adult male have much higher testosterone levels than adult female. This result must be compared to an appropriate reference value based on sex and age. Hypothalamic or pituitary disease. Decrease in hypothalamic pituitary disease. Some genetic disease associated with testicular failure and infertility or chronic disease. Males, increased testicular and adrenal tumor. Decrease in testicular and adrenal tumor. Early puberty, congenital adrenal hyperplasia in babies and children. Use of anabolic steroid. Female, increase in polycystic ovarian syndrome, ovarian and adrenal tumor, and congenital adrenal hyperplasia. Beta human chorionic gonadotropin. Beta human gonadotropin is a protein produced in placenta during pregnancy in non-pregnant women. No PHCG is detectable in pregnancy. Beta HCG double every 2 to 3 days during the first weeks of pregnancy. A test of beta HCG is either blood or urine. It's used to confirm pregnancy. This detection of beta HCG may be qualitative or quantitative. Qualitative tests can usually detect pregnancy about 10 days after a missed period. Quantitative tests are most often used to detect an ectopic pregnancy or to monitor a woman after miscarriage. Increased pregnancy, ectopic pregnancy, gestational trophoblastic disease, or germ cell tumor.